So much for coming to this meeting. So I'll be talking about pediatric respiratory conditions. So it's the bread and butter of pediatrics is respiratory. So yeah, as Mahesh was saying, my name is Kokal and I'm a pediatric ST1 trainee in Northwest London at the moment. I've recently ventured into medical social media. So I've been on Instagram by the name of the Peds Doc, where I regularly post exam style questions and life's a pediatrician for those who are interested in pediatrics. So give it a follow. And also you might notice that I'm going to be using PolEV. So if you see in this corner, polev.com/the PedsDoc078. If you could go online onto the internet, log on to that, or if you don't have that, you can text this to participate in the exam style questions that I'm going to be using throughout the talk. Okay, so let's get started. So first is just a recap of the respiratory system. So in respiratory pediatric medicine, we're talking anywhere from the sinuses down to the alveoli of the lungs. So the key areas for you to be very aware of is the epiglottis, the trachea, the bronchioles, and the alveoli, okay? Because each of these areas are going to be affected in pediatric respiratory cases. So let's get going. So yes, it's commonly affected in children. So the most common issues in respiratory pediatrics is infection. So a lot of the time you would see a lot of different types of infection of these different areas of the respiratory system. And then we have obstructive and restrictive problems. So obstructive problems, we're looking at, if you all cast your eyes back to spirometries and use of spirometries, we look at the FEV1, so the forced expiratory volume in 1 second, over the forced vital capacity. So in obstructive problems, this is less than 0.7. And obstructive problems are conditions such as asthma, cystic fibrosis, bronchiectasis, or a foreign body. So this is where there's a ventilation mismatch. So you don't have the oxygen going to the alveoli for gas exchange. So you have this FEV1 over FVC, which is less than 0.7. Restrictive problems, on the other hand, are when you have FEV1 over FVC, which is greater than 0.7. So this is where there is some kind of anatomical abnormality, for example, such as scoliosis, obesity, neuromuscular disorders, that leads to this mismatch. So the oxygen's getting there, but the surface area is affected by some form or another. Therefore, there's a mismatch between ventilation and perfusion. So now I just want to, if you could all get involved, I just want you to tell me, name me some signs of respiratory distress in children. And it should work. Okay. So if you can get involved. So this is just an open exercise. So, okay, so we've got a few. So flaring, tracheal tug, tachypnea, recessions, head bobbing, cyanosis. Yeah, good. You guys got quite a lot there. Good. I think the biggest one is nasal flaring we've got there. Okay. So let's go back to the slides. So yeah, fantastic. That's all signs of respiratory distress. So this first picture, anyone want to hazard a guess what this is? You can unmute or put it in the chat, either way. Anyone? Oh, I think everyone's a bit scared. Let me just look at the chat. I'll look at the chat. Intercostal recessions. Yes, that's it. It's intercostal recessions. As you can see, the intercostal muscles, which are in between the ribs, are working overtime. This happens because, so let me go through all of them and then I'll discuss why. So the next is, what's this? Anyone have an idea what this is? Yeah, so we're getting some nasal flaring. Yeah, so this is typically what nasal flaring looks like. So dilation of the nostrils. Okay, so this third picture, what's this? Subcostal recessions. Yeah, exactly. So this is lower down. So this is where the diaphragm will be. So you have the subcostal recessions at this area. And the final one, what's this? Tracheal tug. Yes, exactly. So yeah, so all of these are signs of respiratory distress in children. And the reason why this happens is because children, they don't tell us when they're feeling short of breath. So to try and compensate, they use their accessory muscles, which is all of these, to try and increase that surface area volume ratio for them to inhale oxygen. Okay, so they show it by all of these muscles working overtime. So what commonly happens, and commonly that you will see in children, is that because they're using these muscles more so, they're using up more energy, they become more tired, and the classic symptom in children obviously less than 1 year is poor feeding, because they're using all their energy to breathe, to use all these muscles. So poor feeding is a big sign that there is signs of respiratory distress as well. Okay. So now I'm going to go through a case approach. So we'll first go through the case, and then we'll go on to Poll EV with the single best answer questions out of 5, okay? So the first case, we have a 3-year-old boy who comes in with a 48-hour history of low-grade fever, a cough and runny nose. Mum is concerned that he's passing urine less than normal. Examination just shows a red throat and ears are red bilaterally. Otherwise, examinations are normal. He comes in, his fever settles with paracetamol and some ibuprofen, and he otherwise looks well and obs are all stable. Okay, so have a think. So what's the most likely diagnosis in this child? And we'll go over to Poll EV. Let me just... So let's go to the next question. Okay, so what's the most likely diagnosis in this situation? I'll let people answer and then we'll get to it. Okay. So 64% think upper respiratory tract infection. I'll wait a few more seconds. So it seems like it's in between bronchiolitis and upper respiratory tract infection. Okay, fine. So let's go back to these slides. So let me highlight this. So the key points in this scenario is this child is 3 years old, so they're a toddler age. They have a short history of a low-grade fever and a cough with a runny nose. Okay, so this kind of suggests there's some kind of upper respiratory thing going on. Okay, the examination is otherwise normal, so we're not hearing any crepitations, we're not hearing any wheeze in the chest, which is also a good sign. And his fever is settling with his obs being stable. So the majority of you are correct. This is a common case that comes in A&E, and it's upper respiratory tract infection, okay? So majority of children with a short fever and a sore throat most likely have an upper respiratory tract infection, okay? And the most common cause of this will be viral, okay? So toddler age children is when this happens, when they're going off to, daycare, they're going to nursery, etc. They pick it up from each other, and it comes in kind of peaks and troughs with seasonal variation. Obviously, winter being more so common, but upper respiratory tract infections happen throughout the year, and this is your common thing that comes into the GP surgery majority of the time. Okay. So the common things are rhinoviruses, adenoviruses, and the common cold, which is actually coronavirus, but that used to be called coronavirus and now it's COVID, but the old coronavirus is the common cold. And sore throat is commonly caused by strep. So in general, because these are all viral conditions, they're self-limiting. So you wouldn't actively do much for these children. You just, if they come into your GP practice or come into A&E, because the majority of parents will be worried, especially first-time parents, and they want you to sort them out. So what we do is supportive management. You give them paracetamol and you give them ibuprofen, okay? And you tell them to alternate this and try to make the child more comfortable. And as soon as you give them paracetamol and ibuprofen, they're running around, they're happy, the obs will stabilize, and okay, this child is doing well. Okay, so you commonly, when you're on your pediatric patients, you'll notice that, the pediatricians do something called an oral challenge. So an oral challenge is where we give the parents a set amount of fluid, and then they use syringes of 5 ml. They get the 5 ml of the fluid and they give it to the child. So we're monitoring how much fluid the child is taking. Okay, because obviously if their throat is painful and they don't want to swallow, they're gonna get dehydrated, and that's gonna lead to further problems. So we're gonna try and give them paracetamol, ibuprofen, and challenge them with fluids to make sure they keep it in. So you commonly will hear the parents saying, "Oh, my child is not weeing as much as normal," because obviously they're unwell, they may have a sore throat and they don't want to swallow. So it causes them to be dehydrated. So the main aim in coming into A&E, you give the oral challenge, you give the supportive paracetamol, ibuprofen, and observe. Okay, everyone happy with that? Anything in the chat? So someone's asking about antibiotic strep throat. Okay, let me go and I will discuss that in a second. So your other differentials for this case would be tonsillitis, okay? So tonsillitis can present around, a bit later on, but young children with similar sort of picture of not taking solids as well. They have pain in their throat, etc. So for differentiating the two, we obviously examine the child, and the common pathogens are group A strep, okay, that cause tonsillitis. And to differentiate this, and as to answer the question that one of the students asked, you would want to treat if it was tonsillitis, but you use a criteria. And the criteria is known as the CENTOR criteria, and I'm sure many of you have heard of it. And a good mnemonic for remembering it is CENT, C-E-N-T. Okay, so cough absent, exudates, so tonsillar exudates, cervical tender cervical lymphadenopathy, and temperature. Okay, so if if there's two or more of these present, then you would consider that this child may have a bacterial, as you say, a strep tonsillitis, and you'd want to treat. So normally we examine the throat and we look for these signs. So if there were any signs of exudate and the child has these tender cervical lymphadenopathy with this high temperature, cough absent is not always the case, because sometimes the kids do have a cough, and that could just be because they routinely have a cough. So that one is not as commonly looked at, but the other three, yes. So these patients are treated with Pen-V, so phenoxymethyl penicillin, okay? And the reason, so obviously some of you may think, oh, we should give amoxicillin, because that's the common antibiotic we give in pediatrics if they have a pneumonia, or etc. But we avoid amoxicillin due to a maculopapular rash that can develop if the tonsillitis may be caused by Epstein-Barr virus. Because obviously Epstein-Barr virus can present in a similar way. Doesn't typically have exudate, but it can do. So you avoid amoxicillin at all costs, and you give phenoxymethyl penicillin in this case. Okay, so I want you all to remember that. And I want you all to remember the mnemonic for CENTOR criteria. So cough absent, exudate, nodes, and temperature. Okay, and it's by temperature, what I mean is a temperature that's greater than 37.7. So 37.7 is a low grade fever. So anything above that is a fever in the child. And also, when we're on that note of fever, be extremely wary of how the parents are measuring temperatures, because when you use a strip thermometer on the head, it is not accurate. The best way to measure temperatures in a child is using auxiliary, rectal, and oral temperatures are the main ones to use. You can use the infrared ones in the ears, but they're also not as accurate. Yes, so someone's asking, so if the patient had a penicillin allergy, then you use macrolides. Yes, that is correct. So if the patient is known to have a penicillin allergy, then you would go to a macrolide. Yeah, that's correct. So that's things like clarithromycin. So, and so for the first answer, some of you chose bronchiolitis, and we'll go into discuss some further cases, and I'll tell you why it wasn't bronchiolitis. Okay, so this is case 2. So Alfie is a 5-year-old boy, and he presents to ED with a cough which his mum describes as barking. Over the last 24 hours, it seems to be getting worse. He's otherwise well with a low grade temperature, so 37.8. On examination, you can hear a harsh inspiratory stridor when the child is distressed, which isn't present at rest. What is the most likely diagnosis? So if you can get involved with POL EV, I'll give you some time to think. Let me just move it on, and then we'll come back to the question. So you can answer that now. So my options for this case were croup, upper respiratory tract infection, bacterial tracheitis, or epiglottitis. Perfect, 92% chose croup. Okay. So yes, so the key things in this history are this child presents with a barking cough, so it's barking, and it's over the last 24 hours, so acute, and he's otherwise well with a low grade temperature, and you hear harsh inspiratory stridor, okay? but the child isn't distressed. So these are all pointing towards a diagnosis of croup, okay? Oh, sorry. So croup. So what is croup? So croup is AKA laryngotracheobronchitis. So as it says on the tin, it is inflammation of the larynx, the trachea, and the bronchi. Okay, so you have swelling of the thickened smooth muscle and narrow lumen, and that leads to this classic barking cough in children. It's commonly caused by human parainfluenza virus. So this is another thing caused by a viral infection. And yes, it presents the classic barking cough. And in exams, you'll see kind of seal bark, etc., things like that. So severity can be scored by something known as the Wesley score. And it just looks at whether the child is distressed at rest, if you can hear the stridor at rest, etc. So if the child is otherwise well, so it's mild, so you have the child is well at rest, and you can't hear the inspiratory stridor at rest, but they have the barking cough, then it's kind of just supportive. So just supportive management, as you would do with upper respiratory tract infection. You don't really do anything. If the child has this inspiratory stridor, like in this case of Alfie, and the child has this barking cough, etc., then you give a dose of dexamethasone. So steroids is the treatment, and it works by obviously reducing the inflammation and opening up the airways and reducing these symptoms, okay? And then you can also give nebulized adrenaline as well, which is commonly given if the croup is more severe, okay? Let me just look at the questions. So I thought you always give a single dose of dexamethasone regardless of severity. No, that's incorrect. So if the child is well, you only monitor them. So you may just have a barking cough, but which settles, and there's no stridor on examination. Then the child, you don't need to give dexamethasone. Obviously, this may vary from whatever trust, where you work, what trust you work at. But we use the Wesley score at the trust I work at, and if it's mild, then you do not give any steroids. You only give the steroids if there is this inspiratory stridor at rest, okay? And is there an age group for croup? Yeah, so generally it tends to be from toddler all the way up to around, school-age children. Primary school-age children will tend to get this. Okay. So yes, if it's really severe, so if the child is really unwell, struggling to breathe with low SATs, etc., then you call the anaesthetist, IV steroids, so normally hydrocortisone, and then oxygen support, as you would do with other respiratory conditions that are severe, okay? So it's a condition that commonly occurs, and it occurs in the winter period normally. And you'll hear, loads of children, they're barking left, right, and centre. But you need to try and triage and make sure that the ones who are less severe don't need any, supportive. Those that are really, really unwell, and those that are just in the middle, you give a dose of dexamethasone. You observe them for 4 hours, make sure they're eating and drinking, and they're otherwise saturation or observation are stable. Then they can just go home with safety net advice, okay? The bacterial tracheitis will be high up in your differential with croup, because they do present very similarly. So as you can see in this image, so usually between 3 to 5 years, fever with a barking cough and stridor. So it sounds like croup. But the difference is mainly is that this presents, the child will appear very septic and unwell. Like you'll see these children from a mile away because they look so unwell, as opposed to croup where they're generally not as well, okay? So it's rare compared to croup, and it's caused by Staph aureus. So that's the most common cause of it, and it causes this kind of pseudomembrane and mucopurulent secretions, as you can see in this image of this rigid bronchoscopy. So it is an airway emergency, okay? So you need to call the anaesthetist ASAP, start them in broad spectrum antibiotics, IV fluids, and then ENT will need to be present as well if they need to do a rigid scope, okay? So yeah, so that's the main difference from croup, if everyone understands that. So the child will appear more unwell, they'll be septic, and you get the anaesthetist straight away, and you give IV antibiotics, while croup you don't give antibiotics, okay? Because of the causes difference. So people are asking about how you differentiate from severe croup. So obviously, if the child is coming in really severe, with severe croup, with difficulty in breathing, it can obviously be like bacterial tracheitis, but they won't be as septic or to that level. But yes, they'll be unwell. So a lot of these cases, they're your main differentials. So you need to manage as appropriate. So your first thing, as you know, as you all know, is the ABCD approach. The first thing is the airway. So you need to manage the airway in your first instance, regardless of what the diagnosis is. Because sometimes, yes, they may come in, you don't know the diagnosis yet. You know, from the history, you just have to go with your ABCDE, manage the airway, stabilize the patient, and then go from there. So if you're unsure between bacterial tracheitis and croup, yes, you would give the steroids. Yes, you would give the antibiotics, okay? Everyone happy with that? Let me just have a look at the questions. All of these things, yes, you have to try your best to try and not upset the child due to the risk of airway compromise. So yes, whenever these cases come in, the anaesthetist should be there. And when they come into ED and they're looking septic, they usually would come with, they come kind of blue lighted. So they usually go straight to resus, and the anaesthetist is obviously fast bleed regardless when that goes off. So they will be present. So antibiotics, well, it'd be a broad spectrum antibiotic that you would use because it's staph. Fluclox would be your top, right? Okay, so it will be kind of a penicillin, but Fluclox is the first line for any Staph aureus infection. Yeah. Okay, so case 3. Okay, so Sophia is a 4-year-old girl who is otherwise well. She's unvaccinated. She presents to ED with a temperature of 40 and sudden onset difficulty in breathing. On examination, there is a harsh inspiratory stridor. She looks very unwell and is drooling profusely. Okay, so from this history, look at the key points and see what is the most likely diagnosis. Okay, but yes, there will be some differentials that you need to consider, but what's the most likely diagnosis? So is it croup, epiglottitis, pneumonia? Someone chose acute asthma, it's gone now, it's gone to epiglottitis. But we'll discuss why this is epiglottitis. So this, obviously, in this case, the main thing. So as a rule of thumb, whenever you do your exams and you have a case, highlight the points that are most important. So it's buzzwords that are really important. And the buzzword in this case is unvaccinated. And that immediately makes the child has probably got epiglottitis, because HIB, which is what causes epiglottitis, is given in the routine vaccination schedule in the UK. So we're missing that in this child. So we're thinking, oh, so this child they're unvaccinated, they're higher risk of epiglottitis, okay? But your main differential, top differential for this would be bacterial tracheitis, okay? So life-threatening epiglottitis, the life-threatening emergencies. This is sudden inflammation and swelling of the epiglottis, okay? As you can see in this image, it looks kind of red, raw, extremely swollen and painful for this child. And this can make this can obstruct the airway completely, okay? So it's very, very serious, okay? So anaesthetist needs to be there from the get-go in this child. So it's caused, as I said, by Haemophilus influenza B, and it's less common now due to the vaccination program, as we give it with the 5-in-1, and so you need to go from you need to think of that when this child has been unvaccinated. So this will rapidly lead to airway obstruction. As you can see from this image, it's almost completely blocked off the airway. So this child and so you call the anaesthetist early. Do not examine the throat or do anything to aggravate the child. Okay, so this child needs to try and keep them calm, and the anaesthetist will intubate immediately. Okay, and we give them a broad spectrum antibiotics, and they need to be managed in a tertiary pediatric intensive care unit, because these children become really, really, really unwell. Okay, so in the questions, I think there was. People asking, how do you differentiate this from bacterial tracheitis? So the reason why epiglottitis is the main answer for this question is because in the question it said child is unvaccinated. So the top thing you think about is epiglottitis. But yet again, as I say, it's still A to E approach. So airway managed first, and then after, so you will give the antibiotics, and you will treat this child with antibiotics and fluids and steroids. Okay, but obviously later on, you know, when the anaesthetist comes and they examine, you'll be able to tell the epiglottitis because you will see this if you did the bronchoscopy. Okay, and bacterial tracheitis, you'll see the pseudomembrane, which is different. If you remember the picture, let me just go back. So this is, think of this is epiglottitis picture. And that's the bacterial tracheitis. There's like this white kind of pseudomembrane mucopurulent secretion, which is completely different if you look at it, right? So that's how you will know after the anaesthetist is there and they've analysed the airway that this is epiglottitis over bacterial tracheitis. Okay, so I hope that answers your question. So next, so case 4. So James is a 7-month-old who's brought into A&E due to a low-grade temperature and poor feeding. He's been generally unwell for the last 2 days, and mum says he has been more congested. On examination, he has intercostal recessions and nasal flaring. And on assessing the chest, listening to the chest, auscultating, you hear bilateral wheeze and crepitations. His observations, his respirator rates are 60, his SATs are 91, his temperature is 37.7, and his heart rate is 145. From this history, what is your most likely diagnosis? I'll let you guys have a look at the question a few seconds, and then we'll go over to poll EB. Okay. So in this history, what do you guys think? Okay, yeah, so majority are saying bronchiolitis, which is correct. There's a few who said viral-induced wheeze and pneumonia, so we'll discuss that in a second. So let's go back to the question. So the buzzwords. So this child is 7 months, so they're less than 1 year. So think of that. They come in with a low-grade temperature again and poor feeding. Okay, generally unwell, and the next one is more congested. And then the final one is wheeze and crepitations are heard in the chest. Okay, so these are the things you're looking out for in this case. Okay, so that all leads me to think. So looking at the observations, I can tell you the respirator rates are raised, the SATs are obviously low, the temperature is low grade, and the heart rate is slightly high. So bronchiolitis is the most common condition in this infant age group, so less than 1 year. And it's caused by the respiratory syncytial virus, so RSV, okay? And RSV, it occurs commonly in the winter months, so it's a seasonal condition. So what happens in bronchiolitis is that the bronchioles get inflamed as a result of this RSV infection, and it causes the child to have difficulty in breathing, which therefore, as we discussed earlier, signs of respiratory distress, causes intercostal recessions, subcostal recessions, nasal flaring, etc. Okay, so these child, you know, as I discussed earlier, will be using up all their energy to try and breathe. So there'll be poor feeding will be the main thing that the mum will say the child is presenting with. So poor feeding, less wet nappies, so the child is not taking in enough. Yes, inflammation of the distal bronchioles. So the management is mainly supportive with bronchiolitis. So it's Optiflow. So for those of you who don't know what Optiflow is basically where we're pushing in a level of peak, so peak expiratory pressure. So you kind of giving them that flow of air, which keeps the distal alveoli open and supports their breathing. So it's plus or minus oxygen. So if the child is desaturating, if they have low SATs, and this child generally we accept above, you know, if it's above 92, okay. Because it's less, you'll give them some supplemental oxygen with the Optiflow. So it's generally just pushing in air, try and keep the distal airways open. Paracetamol and ibuprofen are yes for all cases. So I want you guys to think, in bronchiolitis, in what cases would you consider admission into hospital? So in what cases of, what are we looking out for which would lead to admission to hospital? So yes, we've got some good answers. So we got high fever, less than 50% feeding, low SATs, apneas, SATs less than 92, apneas, underlying conditions. Okay, yeah. So that you're all in the right sort of thing. Yeah. So it's all about so if they're feeding less than 50%, that is correct. So if they're feeding much less than they usually do, then you will put an NG tube in. So in these babies, you put an NG tube in to feed them and monitor their feeding. If they have complete drop of urine output over the last 24 hours, that's a very bad sign. So we need to keep them in. And yes, low SATs and apneas, 100% yes. So if the child is really low SATs, 88%, and they're having apneas, that's really bad. So that child needs to come in for the supportive measures. And if they're coming in, then we would start them at antibiotics. I know it's caused by RSV, but you would give antibiotics if you're worried that this child with children with bronchiolitis can get a secondary pneumonia as well. So you want to cover for that just in case. So you would screen the child if they're coming in with such low SATs for sepsis, and you will also screen, so screening for sepsis and cause being pneumonia of the chest. Does everyone understand that? Any questions for that case? No? Okay, fine. So move on to the next. So yeah, this is your bread and butter. You'll see this a lot as well, bronchiolitis. But remember the age groups. So this one will be less than 1 year, and you have this wheeze and the crepitations. And to go back to some of I answered viral-induced wheeze. So viral-induced wheeze doesn't commonly occur in this age group. And viral-induced wheeze is kind of a broad term, and it tends to happen with, say, our initial case, which is an upper respiratory tract infection, where you get a bit of a wheeze because of the inflammation, but the child is otherwise well. So that's what viral-induced wheeze is. But the other condition, I think someone said, was pneumonia. Yes, we need to consider pneumonia as well. But in this case, with the history, it's bronchiolitis, that they can get secondary pneumonia. So questions, which antibiotic would you use for the prevention of secondary pneumonia? So it will be a broad spectrum antibiotic. So so you would give your cephalosporins, okay? So your ceftriaxone is the one that we use in A&E for our broad IV antibiotic. Okay, if they're going home, we can give oral Coamox is the common thing, but not in bronchiolitis, but more like in infection, pneumonia, tract picture, chest infection. You give Coamox. That's what we give, but obviously it varies between trusts. Would you do a septic screen for all of these cases, or just if they seem very unwell? Yes, exactly. So you would do a septic screen. So any child appears unwell with red flag symptoms, then you would do a septic screen without doubt. Okay. If they obviously have a bit of they're otherwise well, then there's no need to do any of that. But if they are looking septic, you have to do a septic screen. Is that a common prophylaxis? What do you mean? The antibiotic? No, we don't give antibiotic prophylactically for bronchiolitis if they're otherwise well. You would obviously, if they're in hospital, as I said, if they're unwell, you give the IVs. But if they come in and you think it's bronchiolitis, but they're stable and they get discharged home, then you don't give any prophylactic antibiotic. And also, just for you guys to know, and I'm sure you know about it already for exams, for children who are of high risk, so those who are preterm, etc., you would give something called palivizumab. I'm sure you've heard of it. So it's a monoclonal antibody, which is given as an injection to these children of high-risk groups. So I'm currently working in the neonatal unit, and we have preterm babies. These preterm babies, once they're term, they get discharged home and they come back for prophylactic doses of palivizumab to try and avoid them getting bronchiolitis. Because those, as someone mentioned earlier, that's also a risk factor with anything with children. If they have underlying conditions, they're more likely to be more unwell with these viruses. So bronchiolitis will kind of affect them completely. So we give palivizumab to support those. Okay, so good. So case 5. There's a few more going. Is everyone still awake? Right. So this is case 5. So it's the middle of winter. So Lucy is a 12-year-old and she suffered with a respiratory condition and eczema. She presents to ED with a sudden onset, worsening increased work of breathing, shortness of breath, and chest tightness. Her heart rate is 130, her rest rates are 38, her temperature is 37.5, and her SATs are 90%. She's unable to speak in full sentences, and there is a widespread polyphonic wheeze in her chest. So, well, I kind of gave the answer, but what's the most likely diagnosis in this case? Let's open that up. So yeah, 96% said acute asthma. Yeah, that's correct. Oh, someone said a viral-induced wheeze again. I think probably need to explain viral-induced wheeze a bit better. Let me just go discuss asthma, and then I'll go back to that. So asthma, common condition that's going to present in your A&Es and GP, etc. So this is a case of acute severe asthma attack. So can anyone join in the chat and tell me what are the signs that make it severe? Oh, clever one. Someone said atopic triad. Yes, we're looking at that's something, but yeah, that's not part of the severity, but yeah, that's something that we picked up on. So can't speak in full sentences. Yes. So silent chest, is that severe or is that life-threatening? Can't complete sentences, yes. So low SATs, SATs below, so low SATs are specifically, yes, less than 92. Something less than 33%. Okay, we'll get to that. Heart rate over 140. Ooh, okay. Life-threatening. Yeah, life-threatening, yeah. So silent chest is life-threatening. Is this true asthma, but why he's not on any inhalers? Okay, we'll discuss that. Rest rate greater than 25. Okay. So less than 50%. Yeah, so let's say, yeah, so the correct one was, so 33 to 50% peak respiratory volume, yeah. Okay, so let's go discuss that. So this is a severe attack. So asthma is a combination of, the triad is bronchial inflammation, bronchial hyperresponsiveness, and bronchoconstriction. Okay, so these three combined is what makes someone with asthma that typical asthma attack feel. But yes, asthma is also a chronic condition, and it's associated with stimuli such as cold weather, dust, pollen, exercise, etc. Okay. So yeah, so we're talking about, so severity will be based on, yes, a peak expiratory flow, 33 to 50%, if the heart rate is increased, and yeah, if they're unable to speak in full sentences are the main things we're looking out for, okay? But life-threatening, so this is obviously the one we're really concerned about. This is the mnemonic that I've kind of come up with. I don't know if it's that easy to remember, but it's okay. So 33, 92, 8, chest. So 33 refers to your peak expiratory forced volume. So if that's less than 33% of expected or best, 92, so oxygen saturations less than 92%, and the 8, so on your ABG, if the PO2 is less than 8 kilopascals, and then the chest stands for cyanosis, hypotension, exhaustion with feeble respiratory effort, S for silent chest, and T is for tired heart, bradycardia, which is more common, but you can also be tachycardic. So tachycardia, more you see in severe, then life-threatening, they become obviously the opposite. They become hypotensive, they become bradycardic, etc. Okay. I'll give you guys a few seconds if anyone wants to. You get the slides, so don't worry about that. So, so we've had some questions. So what respiratory condition? So this is what I was going to say. So this we are missing, I think people are asking, why this patient's not on inhalers, etc. So this is sometimes the history that you will get. You won't, the parents won't remember things and they won't tell you. So you'll just get, oh, this child has a respiratory condition, especially in exams, actually. They won't give you everything. So Lucy suffers from a respiratory condition. So she has, we're thinking, asthma. As someone was mentioning about the atopic triad, which is asthma, eczema, and hay fever. Okay, so they're atopy causing conditions. So whenever someone has one of those conditions, you should ask about the other two, which is hay fever, asthma, or eczema. Okay, so this child, from this history, clearly probably suffers from asthma. But the main trigger points here that you think about is this eczema, sudden onset, worsening increased work of breathing with high heart rate, SATs less than 92, which is a widespread polyphonic wheeze. Okay. Yeah, I'll show you the chest side again. You'll get the slides, so you don't need to worry too much about rushing down. But here it is. Yeah, I'll give you a few seconds if you want to jot down. Everyone happy? Should I move on? Yeah. Okay. So now the next mnemonic is the management of acute asthma. And I remember it with this one. It's usually a bit more ruder. I'm sure you can figure out which way. But yes, I made it a bit more friendly. So the O is for oxygen. So O hits man. So O is for oxygen, so high flow. H is for hydrocortisone IV. But remember, if a child is not in life-threatening asthma, acute asthma, and they're speaking in short sentences, but that means they're still able to swallow and the airways patent. So you can give them orally. And most of the time, in A&E, we prefer to obviously give it orally because otherwise cannulating, making the child more distressed, etc. So first, you give the oral prednisolone, but hydrocortisone, yes, if it's life-threatening, it's hydrocortisone. I is for ipratropium bromide, so we give nebulizers, 0.5 milligrams. T is for theophylline. So theophylline it used to be used more so, but now in A&Es we use IV salbutamol because it works quicker and there's less. I think some of you know your pharmacology. Theophylline has a narrow therapeutic index, so salbutamol is more. It doesn't have that, and it directly works. So we avoid giving theophylline and we give IV salbutamol now. But part of the mnemonic and for exams, think of it like you do give theophylline. Salbutamol nebs. So obviously salbutamol nebs come earlier up, hence why the other mnemonic. But yeah, so remember it as SHIT man. Okay. And M is for magnesium sulfate, which is given later on. And so after we kind of give IV salbutamol and then magnesium sulfate. Magnesium sulfate, we still don't know how it really works, but it does do the job. Okay. Just have a look at these questions. Can I check? I was told oxygen is, one of the questions, can I check? I was told oxygen is contraindicated due to respiratory center is regulated by CO2. You give oxygen, it causes respiratory depression. So so you're thinking about adult medicine in COPD, so chronic obstructive pulmonary disorder. These patients will have hypoxic drive because of their long-term hypercapnia. So that's completely different. In children with acute asthma, I don't want you to confuse you with that, but with acute asthma, or even adult asthma, you give oxygen, okay? So next. So chronic asthma management. So this is kind of my thing that I've written up. It's the Bts Guidelines for asthma management, the chronic asthma. So children you tend to diagnose them after the age of 3 or 4 when they're able to, they're walking, etc., and you can assess their lung function properly. So looking at this graph, I know it's a lot going on here, but it's a stepwise approach to the ladder. So you usually start with a SABA, so it's a short-acting beta agonist, which is salbutamol. Okay, salbutamol is the bronchodilator, and then You can also give a very low dose inhaled corticosteroids, so ICS. So that is to reduce the inflammation. Okay, but remember, so the main thing to note in this, if the child is less than 5, we start with a leukotriene receptor antagonist. Anyone know any examples of a leukotriene antagonist? Yeah, Montelukast. Yeah, so Montelukast is normally a tablet, and it's given to children less than 5. Okay, so the first step in the ladder will be giving your preventer with your steroid as well. Okay, in the child greater than 5. In younger children, you don't give the steroid; you give the leukotriene receptor antagonist normally. Okay. And then you move on to the initial add-ons, which will be a very low dose inhaled corticosteroid. If they're greater than 5, you add on a long-acting beta agonist, which could be salmeterol. And you can also trial Montelukast as well at this stage. If they're less than 5, then you add on at this stage as well. So you may not consider initially to start them on leukotriene, and then the next step will be start them on leukotriene. And then each step of the ladder, so if the child is greater than 5, it's just increasing the steroids. And then the next stage will be specialist therapy, so consider all steroids and other monoclonal therapies, such as omalizumab. So the main thing for you to take out of this slide is that in children less than 5, you start leukotriene receptor antagonists over steroids. And in older children, you start the steroids, you can add on the leukotriene, then you increase the steroids as relevant, okay? And the important point is at the bottom. So the reason when we move up the ladder is if the child is using more than 3 doses a week, or they're having more symptoms and they're symptomatic, then you'll move up the ladder. But also remember, you can move down the ladder. So if a child is stable on a specific regimen for a certain period of time, you can wean one of the steroids, decrease the doses, and they can go down the ladder as well, okay? Because as some of you will know, some children do actually grow out of asthma, and some don't. Is this NICE or BTS? It's the BTS guidelines, but in your exams and everything, it will be the BTS guidelines normally that they would like, etc. Montelukast is no longer given. So Montelukast is actually still given, and if they're less than 5, you still do give it, because I think you can get other suspensions of it as well. So if they are less than 5, you do give them Montelukast because we avoid use of steroids. Why do you think we avoid use of steroids? Anyone want to hazard a guess? Growth, exactly. So you try to avoid, especially at that critical stage where they're switching between their toddler stage to then their growing phase where their growth hormone is peaking. You don't want to start a steroid too early. So the reason we still give Montelukast if they're less than 5, okay? And let me go up. Someone was saying a respiratory consultant told them if oxygen is still contraindicated. Okay, so that's not the case. So so if you think about it, if the child has very chronic asthma and they're known to be a retainer of CO2 and they have this, then you can obviously consider about being precautious with your oxygen. But in all cases, from your point of view, for your exams, etc., always go A to E. And if you do ILS, if you do your resource council stuff, etc., it's always first thing is giving oxygen to the child, giving action to the adult. Okay, so we don't get bogged down on that thing. Okay, that's for specialists, long term, etc. Okay. Someone raised their hand. You can ask if you want. Go ahead. Ekaterina? No? Okay. Fine. So just a few more cases. So George is 6 and has come to ED with a cough of 4 days. The cough started suddenly while he was playing with his friends at school during lunch when he was noticed to have a coughing fit. He was fine afterwards and continued to play. This cough has continued and he is now a bit short of breath. Mum is very concerned. So on examination, there's slight reduced air entry on the right mid-zone, but otherwise normal examination. Obs are stable at this point. What is your most likely diagnosis? I'll give you a few seconds to read the question. We're almost there, guys. So what do you guys think? Okay, a bit of a mixed bag with this question. So we got 60% thinking foreign body aspiration, a few thinking pertussis, and a few think it's none of the above. Okay. So I want to let you guys tell me what are the buzzwords in this scenario that say it's what you think it is. Coughing fit, yeah. Right mid-zone, sudden, yeah. Right, yeah. Normal obs, yeah. Exactly. So the main things here is the child presents with, he had a cough that started suddenly while he was playing, and he was fine afterwards, okay? And then his cough continued, and now he's a bit short of breath. And then the main section in buzzword is right mid-zone. So the majority of you, 60%, were correct. It is foreign body aspiration for this very reason. So this is the X-ray. And I'm sure you can all see. As you can see, there's a foreign body in the right side. So why do you guys know why, which side is more common and why for a foreign body to get lodged? The right side, the angle, more vertical, yes, exactly. Shorter, more vertical, exactly, yeah. So the right bronchus is more vertical, and it's shorter, and it's actually so that means that children, if they're going to aspirate, more likely are going to get something stuck in the right bronchus. Okay. Anyone know what we would do with this patient before I mention it? Is this patient okay? Do we need to do something? Bronchoscopy removal. Well done. Yes. So foreign body aspiration. It's just a common thing that happens in A&E. Children play with these really small Legos, and I don't know why you give them for children that age, and they always end up swallowing or aspirating onto these Legos, and they always come in like this. So you can suspect it in any child with a sudden onset coughing history. And they normally, the history would be like they were playing with their friends, they were playing with their brother or sister, and they were noted to be suddenly coughing, but then they were fine afterwards. And now they're kind of still coughing and they're not breathing as well. So an isolated sudden cough with normal observation should always make you suspect foreign body. So management is with rigid, so the main thing is rigid, not flexible, rigid bronchoscopy, and ENT are what we need, not anesthetic. So ENT, the ear, nose, throat surgeons will come down and they can retrieve the foreign body by rigid bronchoscopy. So obviously if it's further down, all based on the X-ray, then it needs to be removed in theatre with under general anesthetic. Otherwise, if it's kind of higher up, then they can remove it in A&E actually. And then you always give prophylactic antibiotics because we're worried about a secondary pneumonia. So people are asking, why not flexible? Why do you think not flexible? Okay. So the reason why it's not flexible is because rigid is more the upper part of the airway. So flex, exactly, not to kink. So the flexible will be going kind of flexible bronchoscopy is where we're going further down into the airway. It's very unlikely that a foreign body is going to go all the way down to the bronchioles. It was going to be in the bronchi or upper part. So rigid bronchoscopy is going to be the best way to get that out. Flexible is more for going further down into the lungs. Okay, I hope that makes sense. And yes, you give prophylactic antibiotics, as we discussed, because pneumonia is going to be of concern. So these children need to, even after the procedure, have antibiotics. Okay. I think there's only one more case, guys. Oh no, I don't think it's a case. I think I'm just going to discuss pneumonia. Yeah. So pneumonia is, so chest infections are common illnesses in children, most commonly caused by viruses yet again. So therefore, they are generally self-limiting. Majority of the time, and you'll see this over and over again in GP practice, if a child comes in with kind of this history with kind of signs of respiratory tract infection, the GP will just give them antibiotics. But majority of the time, it is viral and it will be self-limiting. Okay. And so in regards to bacterial community-acquired pneumonia, the general rule of thumb is that less than 5, strep pneumonia is the most common cause, and your treatment will be coamoxiclav. Okay. Greater than 5, it tends to be more mycoplasma pneumonia, and the treatment tends to be more erythromycin or erythromycin. So this is from my MRC PCH Royal College exams. This is what kind of comes up in past tests and all this stuff. But it doesn't mean that you can't get strep pneumonia if they're greater than 5. This is just the common pattern, just for you to think about it for your exams, okay? So it goes without saying, if a child is immunocompromised or has some other condition, then we're thinking more exotic infections such as Pseudomonas, Pneumocystis, Gyrovecki, fungal infections, etc. Okay? And I think, yeah, so we covered respiratory stress, upper respiratory tract infections, croup, bacterial tracheitis, epiglottitis, bronchiolitis, asthma, and pneumonia. And these are a handful of the most common pediatric respiratory conditions that you're going to come across in your day-to-day practice and in your exams, okay?